So welcome to Healthy Living with Mild Cognitive Impairment. Today we are going to be talking about medications, vitamins, and supplements. My name is Bonnie Nutkinson. I work at the Wisconsin Alzheimer's Disease Research Center, and I help facilitate the program. On our planning committee, we also have Jen. Jen, would you like to introduce yourself?
Hi, I'm Jennifer McAllister. I'm one of the program managers for the Alzheimer's Association of Wisconsin chapter, and I'm happy to be here with all of you today.
Thanks, Jen. And then we have Dr. Chin. Dr. Chin, would you like to introduce yourself?
Hi everyone, I'm Nate Chin. I am one of the geriatricians at UW Health, and I'm the medical director of the Alzheimer's Disease Research Center here in Madison, Wisconsin, and the WRAP study, the Wisconsin Registry for Alzheimer's Prevention. I attend all of our events here, and I am excited at this particular topic as well, and look forward to a very entertaining and thoughtful discussion.
Thanks, Dr. Chin. And just some housekeeping items. This is set up as a Zoom meeting, and so you do have the ability to have your camera on and mute and unmute yourself. We ask that you stay muted unless you'd like to speak. I know it's easy to accidentally unmute yourself, so Jen or I may go ahead and mute you if we hear some background noise coming from you. I know I accidentally did that myself the other day at a meeting. Doesn't matter how long we're on Zoom, right? And then as we're going along, feel free to put questions in the chat, and Jen will be monitoring the chat and sharing the questions. We have had a change in our speaker for today, and Jen's gonna go ahead and introduce our speaker.
Great, thanks, Bonnie. So today we have with us Ann Schwartzwald. Ann is a consultant pharmacist with O'Connell Pharmacy in Sun Prairie, Wisconsin. And as Bonnie shared, she's going to be sharing a presentation today on medications, vitamins, and supplements. So Ann, we're so glad that you are able to join us today for this discussion.
Thank you for having me. Yeah, Holly Altenberg was originally going to do this, but she had a family emergency come up. So I have viewed the slides since last night, so bear with me throughout it. I do have many years of experience. I've worked as a consultant pharmacist with O'Connell's and other pharmacies in the state of Minnesota and Wisconsin. We have over 60 facilities that I consult with practitioners, prescribers, patients, and staff that work at the facilities. So I do have a pretty diverse background to cover the topic. So I'm looking forward to talking with everyone and getting feedback from everyone. All right.
Bonnie, you're muted.
Oh, thanks. Sorry, I was just going for it. So thanks so much, Ann. Before we get started with the presentation, I thought we could go ahead and answer those trivia questions. So the first question is, what is the average number of medications in elderly patients? And we had a lot of different guesses, and the answer is 13.
I wish it was lower than that. I'm sure a lot of you have heard of polypharmacy, which polypharmacy is 5 or more medications. And that number seems to keep creeping up higher and higher. We know anything more than 5, we're starting to already see drug interactions. So, and definitely this is going to impact people's cognition. So we keep working on this. It's definitely a work in progress.
And then the next question was, what is the most frequently dispensed medication at O'Connell Pharmacy?
What were some of our guesses?
Lutein or a memory supplement?
Mm-hmm.
And then I think just mine was the other one,
Furosemide.
furosemide.
Yeah. Good guesses. We do have, I'll give you the top three. Nationwide, the top number one is atorvastatin, which is a statin, obviously, for lowering lipid levels, and used a lot in stroke prevention, those issues. The other two that we see are omeprazole and hydrochlorothiazide. So furosemide is definitely in our class with hydrochlorothiazide for our blood pressure control. Cardiac issues are very prevalent. And then omeprazole is right up there too. I think advertising has truly driven that, although with our anxiety in society, we do have a lot of GERD, which we're the gastroesophageal reflex, which omeprazole is targeting. Surprisingly, I wasn't expecting hydrochlorothiazide up there, but I think it's an old, inexpensive drug for blood pressure, and it does work. So I think that was our thrown in there. Furosemide is a good guess. I was just teasing a little bit. Brand name of it was Lasix, and what that stood for. And if any of you have been on it, it's called a water pill, and Lasix stands for last 6 hours. So we're always trying to dose that in the morning so that we're not up at night using the restroom after it's kicked in.
And then the last question is, what supplements are inquired about the most?
Did we have feedback on that, you said?
No, we didn't have anybody put in an answer for that, but what I have on my notes is it's B vitamins and vitamin D is the most inquired about supplements.
And I would throw in there calcium also. I think one of my professors way back when, he always said our biggest questions are bone and brain, pee and pain. So bone health definitely is in there, and that's our vitamin D and calcium. We'll as we go forward, we'll talk more about pain medications. Obviously, that's a big topic. Also, brain. Here we are. We're talking about cognition, and we. But definitely through advertising, see a lot of bladder health medications. Over the counter, we will get more into the vitamin and supplements, especially as it relates to cognition, but we definitely get plugged a lot as pharmacists for these over the counter and supplement items.
Well, thank you very much, Anne, and everybody for participating in our trivia questions. So now we'll move on to the presentation part of our program. So Anne, I'll let you take it away.
All right, great. So we're here to talk about mild cognitive impairment. We're going to go over what things can be causing it or making it worse, and possibly what we can do to reverse those things, if it's possible. What medications we're prescribing are used for this, our vitamins and supplements that we're using to help manage it, and then other things that may come into play that we can help with managing cognitive impairment. Next slide. So when we're talking about mild or cognitive impairment or MCI, what exactly is that? How is that different than natural aging and memory, or how is that different than dementia? And basically what I would say is that's kind of the gray area in between those two. Is it natural progression and there isn't anything we can do, or might this go on and become worse and develop into dementia? And what can we do to stabilize where we're at, either reverse it or move forward with it? And then symptom-wise, how do we recognize that we're having some cognitive impairment? Is it ourselves recognizing it? Or is it a family member or a friend that's bringing it to our attention? And some of those things are made apparent. Maybe we're making poor decisions and someone's pointing those out to us.
Maybe we find it hard to complete our tasks throughout the day. Family members might be questioning us. Remember, I told you this. And so there's some of our triggers that maybe our brain isn't quite working like it used to. And like I said, maybe someone else recognizes those, or we recognize them ourselves. If you're seeing some of these, or someone you know you're seeing these things come up on them, getting them in to see a healthcare provider is important, and doing a full diagnostic workup, what our family history is, what kind of medications we're on, what we do throughout our day, what we're having our most problems with. The prescriber or your physician may want to order some lab tests and do some neurological exams on you. There are some cognitive oral tests they can do too, to check where your status is, that may help relieve some of your fears and may also solidify some of what's going on with you. So we'll get into get into more of this. Next slide. So when we're talking about things that are reversible, one of the biggest things we can look at is medications, and that's my job, right? That's what I do every day. When I go to facilities, memory care, and cognitive abilities, psych issues, these are things that I'm having come up every day. And first thing I'm always looking at is, what is the latest medication that was added? Is this something that's contributing if you have a change in condition, even if it isn't memory? Change in condition can often be triggered by medications. And one of our number one culprits are anticholinergic medications. We'll talk a little bit more about what that big word means as we go forward. But there's lots of prescribed medications in this class, and there's lots of over-the-counter medications that people can be picking up at their pharmacy and not even realizing that this is what is contributing to their memory loss. How do these things contribute to memory loss? Can often be through dehydration. When we have poor hydration, it definitely can affect how we think. And that itself can add to the dizziness, besides if the medication also causes it on its own. Especially like pain medications, we know that they can make us drowsy. Other medications have carryover the next day that can be adding to drowsiness. And all of those things can be contributing to our poor cognition. Next slide. All right, so this is our whole big gamut of all of these anticholinergic medications I touched on just a little bit. So probably number one that I see, and I target right away, I call it low-hanging fruit when I do a medication review on patients, are antihistamines, specifically diphenhydramine. As we age, we poorly metabolize diphenhydramine, and it carries over into the next day. So people can take them for allergies, but they also sometimes use them for sleep. That diphenhydramine is like I said, poorly metabolized. It builds up in your system and can definitely affect your cognition that day or even the next day, and also leads to increased risk of falls. So antihistamines are very touchy. All of the drugs that are listed here, I would say you definitely want to take a look at and see if there's a better choice than what you're taking. So like diphenhydramine, hydroxyzine, those I would say if it's for allergies, we should switch you to a non-sedating antihistamines like loratadine or cetirizine. Here comes that pain or bladder control, the P issue. So we've got oxybutynin listed there. That also comes in a patch form. So sometimes not just the drug, but the way we're giving it can change the dynamics of how it works in our body. So if we switch that oxybutynin from oral to a patch form, we have much less side effects, dry mouth included, let alone cognition issues. We'll talk more about medications used for sleep and insomnia. The over-the-counters, again, like if it has that PM in it, it's probably got diphenhydramine in it, which we know is not great for us for a long-term use. Anxiety meds are also something we're going to see that are in this class. Again, that hydroxyzine, which is really an antihistamine, which we'll get into some of the benzodiazepines that are used for anxiety and how to make a better choice for those. A lot of people pick up things for motion sickness and nausea over the counter. Again, those are antihistamine types, and there are better choices that your prescriber might be able to give you for that. Muscle spasm meds, this is interesting. As we know, we're in an opioid crisis, and as we are gratefully reducing opioid use, unfortunately, I am seeing muscle relaxant use skyrocket. So, which may be appropriate rather than treating pain. If we can release those muscles from spasming, we can control them. But the muscle relaxants like cyclobenzaprine, there's a number of them out there, can really affect cognition. So we want to be careful with those and make sure now we're not overprescribing muscle relaxants. There's a few more listed here. We will get into antipsychotics later also. Next slide. So this was part of what we were just talking about. Benzodiazepines, again, if we're using them for anxiety and sleep, there's a number of different choices to make here. Lorazepam versus clonazepam versus alprazolam. Some of those are shorter acting, quicker acting, versus some of them take longer to activate and some of them last longer. So we want to make sure we're making a good choice with those if we are needed. A risk with memory, again, is if we're treating sleep, we have to be very careful. Obviously, a reduction in sleep can affect cognition, but if we're using some of these, we may actually be making that cognition worse, even though we've improved sleep. Opioids, kind of the same thing. We have many different choices to use. Again, can we be managing with a non-opioid that maybe has less of a cognition impairment risk? So those are definitely things to keep in mind, and that may be causing or worsening memory cognition. Next slide. Besides medications, there are some other possibly disease states linked to memory impairment. Diabetes, for one, too high or too low of blood sugars could be having an effect. High blood pressure, we know, can have some effect, as well as the medications used to treat it. Interestingly, high cholesterol can affect our cognition, but we also know the statins used to treat high cholesterol can also sometimes affect cognition. The good thing with the statins is there's a number of them to choose from. And if you are having reduced cognition on a statin, it's reversible. So they can easily do a trial of reducing that statin or eliminating it. And within a couple of weeks, know that that was a statin that was affecting you and your cognition. Couple other things, depression. Sometimes when you're starting to feel like you're having reduced cognition, it might actually be depression. We often talk about depression masking as a memory loss. Smoking can contribute to it, as well as excessive alcohol use and sleep apnea. Again, we're going back to sleep. So sleep apnea is where you have either you stop breathing or you have shortened periods of stopped breathing, which definitely can contribute to cognition and poor sleep. You wake up pretty exhausted in the morning or have continual exhaustion throughout the day, sleep apnea is something to think about. It's more prevalent than we have thought in the past. And there are CPAP machines is what they're called. You'd have to have a sleep study done, and those are a great alternative. Medications that we give as hypnotics to help people sleep can actually make sleep apnea worse. So in those instances, it's going to worsen cognition. So definitely something to look at when we are looking at doing a complete review on someone who comes in with some cognitive impairment, are looking at all of these disease states, and they can be interrelated, right? The smoking can add to increased blood pressure. So these can all be interrelated. Next slide. Oh, actually go back one. This one, so infection we didn't touch on, right? So it used to be as soon as we had an altered state of cognition in people, we immediately suspected infection. As you all may have heard, antibiotic stewardship is a big push. Maybe I just know about it because I'm the pharmacist, but infection can alter cognition and can alter memory. But we shouldn't be jumping to infection right away. We shouldn't be treating infection unless we know it really exists. Used to be we prescribed antibiotics right away empirically. And we know that broad spectrum antibiotics can increase incidence of C. diff, which can be very detrimental and hard to cure, as well as it's creating some antibiotic resistance in patients. So we definitely want to be aware of infection, but not jump right away to prescribing antibiotics on everyone. Next slide. So dementia versus delirium, this goes back to our disease states and doing a good history on someone who's having memory impairment. And I get a lot of questions about delirium versus dementia. And this slide is very good at breaking those two apart. So when we talk about memory impairment and dementia, usually a slow, gradual onset versus delirium is usually a rapid onset. Again, progressive with dementia. In my field, when I'm at facilities, they'll talk about people sundowning. That would be delirium and not dementia. The short-term memory loss is with both of them as well. It has to do with inattention versus attention. Dementia is where we see that without inattention. Dementia psychosis is really not as common as you'd think. A lot of people, when we're talking about psychosis, again, it should be delirium that we're looking at and not treating it based on dementia. And usually with delirium, it's a daytime event. We're not seeing disrupted sleep with it. So that's also a good delineator between the two. All right. So I hope you got out of that sometimes medications can be a cause of cognition issues and possibly reversible. So like I said, when I look at a medication list and I have some with a change in condition, that's probably my number one thing to look at is what new medications are they on? What medications are they on that maybe aren't appropriate any longer? Or what can we make a better choice of medication for them?
So Anne, we have a question in the chat related to medications, and the question is, I am taking oral ketotifen.
Mm-hmm.
Is that the same as diphenhydramine for cognition?
No, ketotifen is actually a non-steroidal anti-inflammatory. So it's usually used for pain or inflammation.
Great. I think that was the only question we had in the chat so far.
Okay.
Mhm.
You're right. Okay. All right, our next section is going to be what medications are out there for treating issues with cognition. All right, so we don't have any, we don't have any actual FDA approved medications for this gray area for mild cognitive impairment. We have medications that are specific for dementia. We're trying to take best use, and some of these medications that are approved for dementia, we're going to maybe use as our first or second step off label for treating it. First step is always, as we've talked about, figuring out, maybe doing that good family history, that good workup, seeing what maybe what underlying conditions we can treat or eliminate first. And again, then what we're looking at here is seeing if we think this may be progressing, then we want to try and stabilize where we're at with memory and prevent further memory impairment. We do have the cholinesterase inhibitors. Another big word, goes back to our anticholinergic issue, but those would be these medications: donepezil, brand name Aricept, ribostigmine, Exelon, galantamine, and then our latest approved medication that just was approved in June, and I'm not even sure how to pronounce this, Aduhelm, I believe is what it is. We'll hit on these as we go forward. I do see another question popped in here: are Claritin and Zyrtec problems? So all antihistamines can affect cognition, even the newer generation ones. But Claritin and Zyrtec, that would be loratadine and cetirizine, are definitely better than diphenhydramine or hydroxyzine. So if you have chronic allergies, it's something to discuss with your physician, but those would be the better choices for you. We will be coming to memantine also with our medications for treatment. So next slide. All right, and I don't know if we were able to make this, there's a little video linked with this slide. If we want to try and get it to run, it'll explain how these cholinesterase inhibitors work. And I don't know if there's sound with this. It might not come up. So she's drawing a basic neurosynaptic model. And I can chat through it otherwise. I'll just chat through it. So the synapses is obviously where nerve conduction happens. And when we're relating to memory, that's definitely an issue. So the circle is right in that area, the synapse. So on one side you have of that membrane, you have release of neurotransmitters. The synaptic cleft is that area in between them. And the other side, you have receptors. And we know patients who have low acetylcholine have the biggest issues with memory and learning. So that's what that neurotransmitter is related to. So that class of drugs I showed, the donepezil included, those are cholinesterase inhibitors. Whenever you see that ASE on the end of something, that means it's an enzyme that breaks something down. So these inhibit the enzyme that breaks down acetylcholine, which then would increase amounts of acetylcholine. So, and by increasing acetylcholine, we hope we're triggering better memory and learning. So that kind of gives you a gist of how that class of drugs works. So even though we may not have progressed all the way to dementia, we have these medications that block that enzyme inhibitor so that we are not getting that breakdown. So we talked about donepezil, Aricept. That was one of the first ones that came out. It's usually taken at bedtime with or without food. Some people do find it disturbs their sleep. In that case, I would recommend moving it to the morning, but typically it's given at bedtime. It's usually started with a 5 milligram dose and worked up. Biggest side effects we see with this, as every drug is a double-edged sword, as we do see, like I talked about, some disturbance of sleep, nausea, vomiting. Some people, it causes excessive drowsiness, which is more common than a sleep disturbance, which is why we give it at bedtime. And then some people get headaches with it. You know, like I said, everything is a double-edged sword, but it was our first drug that we found that was helping with cognition. As a pharmacist and prescriber, things to think about with this, again, anytime we're adding a medication, is drug-drug interactions. This one has a big one with antifungals and antibiotics that can affect QT prolongation, which has to do with heart conduction, so heart rate, and can be quite significant. So we definitely want to keep an eye on that. Also interacts with antipsychotics in producing this QT prolongation. One good thing is it does come in orally dissolvable tablets. So some people who have swallowing difficulties, that can help with that, and a liquid as well. Next slide. Next one in this class is rivastigmine. Again, works the same way. Usually twice a day dosing with this one. If people cannot swallow those capsules, they can be opened and mixed with water to help. A good one on this one, it also comes in a patch. We haven't touched on this, but all of these cholinesterase inhibitors can also trigger bladder issues because of how they work. A patch is a good choice for this one. If you're seeing issues with urinary incontinence, when you start on a drug in this class, is to switch to a rivastigmine, or Exelon would be the brand name, patch, so that we're getting less of that concentrated in the urine. We're just getting bypassing that whole portion of that side effect. This one does have a drug interaction, again, with beta blockers causing a slow heart rate, which beta blockers are prone to do anyway. It's part of how they work. So again, nausea, vomiting, also big side effects with everyone in this class. So those are important side effects to keep in mind. A lot of times people with reduced cognition can sometimes have poor oral intake, so they're not eating as well and start to lose weight. So a big thing to keep in mind when we're using the cholinesterase inhibitors is watch for that nausea, vomiting, and watch weights. So make sure that we're not adding to that weight loss. All right, next slide. Galantamine is another medication in this class. Also comes, works the same way, comes in a short acting and a long acting. Obviously, as a compliance issue, long acting is great. We only have to remember once a day. But again, when we're starting somebody on a medication, I would usually recommend starting on a short acting. That way, if we're seeing side effects, we are able to discontinue and eliminate quicker. We always talk about start low and go slow when we're adding medications. So Even though this comes in a long acting, I would recommend starting with short acting multiple times a day, see how it's working for you, and then switch over to the extended release once a day. Similar side effects with this. One big thing with this one is it does affect liver and kidney function. So would want to do baseline labs for that, and then continue to monitor at least annually to see how that's affecting, or watch for symptoms related to reduced liver function. And again, drug interaction with anticholinergics. So those anticholinergic medications we talked about, those ones for bladder control. So again, it's like a prescribing cascade. Sometimes we'll see somebody put on, they're put on a medication for bladder control. They start to have poor cognition, possibly due to that medication. Then we're throwing on a medication for cognition, and now it's reversing the effects of the bladder control medication. So we'd be better off just deprescribing both and seeing where we end up, and then go from there. Next slide. All right. So the new med, Aduhelm. So this just came out. It was approved in June. It's a monoclonal antibody. So targeting the beta amyloid plaques in the brain. So it's breaking down those plaques. And they have very well proven that it does break down the plaques. The question remains about how well this is affecting cognition. So we haven't seen anything that works like this before. We know these plaques exist in people with cognitive issues. And so a novel new medication, I've, in my history, I haven't seen many new medications come out that questioning the efficacy. So strangely, when they approved this, they actually wrote in the approval that continued approval will be based on confirmatory trials. So they are letting people use this, they're trying it, but it's almost on a trial basis. We still haven't truly proven full efficacy of this medication. I'm a little concerned about the side effects relating to amyloid issues, which a lot of issues with swelling in the brain, which they're having to do MRIs to look for. So it's not inexpensive. It has to be done as an IV infusion over an hour's time. So quite expensive in a clinic. And then the evaluation of making sure we aren't having side effects can also be spendy. All right. I do see in the question, someone was asking about bupropion as a smoking inhibitor. And then something about explaining the nausea, vomiting, and diarrhea. That's the NVD, that's what it stands for, nausea, vomiting, and diarrhea. Bupropion is a antidepressant that is also used for smoking inhibition. It's slightly different dosing. And I don't know if the NVD question is relating to bupropion. And I'm not really sure how the bupropion, it's not something I'm familiar with how it works for smoking inhibition. I do believe it, has to do with reducing of urges. So they still recommend a smoking cessation plan if you try that. If you have more questions related to that, just pop them in there. All right, next slide. No, and that was that FDA accelerated approval. Like I said, I haven't, Aduhelm there's much discussion going on about it, and what trials you can get in on to get it, and how long it'll stay approved, and whether they'll pull this approval or not. We'll wait to see. It's exciting. To see a new medication come out. Hopefully we see good results with it. Someone had asked about memantine. So these are some other common treatments for cognitive impairment. Again, not fully FDA approved for mild cognitive impairment, more for dementia. So Namenda, as you can tell, that brand name is related to how it works. The NMDA receptor agonist, N-methyl D-aspartate is a receptor that's related to glutamate. And we know that glutamate has a role in the health and communication of our cells. So you'll often hear people talk about glutamate when we're also talking about ALS, Lou Gehrig's disease, and even generalized anxiety disorder. So we know glutamate plays a role, and we know that this medication works along that line. So we often, and has a minimal side effects and harm. So often our first two meds we're going to reach for are donepezil and memantine. Both have been around for a long time, and both can work in combination for many patients to improve cognition, or at least hold still where we're at. And stabilize our memory loss. Most often we want to see them given early on. They're not going to reverse this disease, this memory loss, but they can prevent progression. Again, side effects with memantine are the common GI issues, diarrhea, reduced appetite, weight loss. And then also headache is another common one. We're affecting neurotransmitters. So a lot of these are going to have a possible headache. And sometimes that's even just missing a dose will trigger a headache, or taking a dose later in the day than when you normally would. I'm going to just talk briefly on Nuplazid. So that came out a few years back, and the company was pushing when it first came out to use it as a memory health medication, but that has been rejected as for dementia-related psychosis. It is truly for people with Parkinson's who are exhibiting psychosis. And sometimes that is hard to disseminate between memory loss and psychosis. Again, relate back to that delirium versus dementia issue that we kind of talked about earlier. Is it sudden onset? Is it progressive? Is it happening only during the day? Do we have disrupted sleep? Look at those things. And then underlying, do we have Parkinson's on board? It works amazing for psychosis related to Parkinson's disease. It's a very expensive medication, and to get approval, we do need to establish that first you have Parkinson's, and then you definitely have a diagnosis of psychosis related to it. So cannot be used just for dementia. There are some newer things. Nemzaric is a combination of memantine to donepezil, which again, you wouldn't want to start with it because our start low and go slow. But if you've been stabilized on both donepezil and memantine, kind of a nice thing to throw it together in one pill and only have to take one pill, and remember to take one pill. And again, next slide. One more thing. So this is a newer medication, Belsomra, which has been approved for treating sleep. It's we get a lot of questions about Belsomra. It has to do, how it works is it inhibits something called orexin, which plays a role in our sleep-wake cycle. So we know that a poor sleep cycle can affect cognition. So we're kind of excited about this medication to see if we can get a normal sleep, it can help get a normal sleep cycle established. It is very rigid in how we use it. It has to be given a half hour before bedtime, and we need to make sure we are going to be reclined and ready for bed for at least 7 hours. So it continues to work in your brain. It inhibits orexin, and what orexin does is send signals throughout your brain saying, it's time to wake up, it's time to wake up, it's time to wake up. So if we're going to use this, that effect lasts for 7 hours. So we need to make sure you are ready to be reclined and asleep for 7 hours. So otherwise we're getting a lot of carryover into the next day. So we need to really watch for that. And how it works on that orexin, we're seeing some strange dream effects. So it's not for everybody. A lot of people don't like it. They're like, you know, because of that issue with affecting dreams, it's just not the drug for them. All right, next slide. All right, so all of those medications are approved for Alzheimer's and or dementia specifically, not for just mild cognition impairment, but we also know we need to give these early on in cognitive impairment in order to stop that progression. So like I'm anxious to see how the new monoclonal antibody plays out. I don't know anybody who's on it yet. So if anybody has an input on that, that would be great. I don't know. I don't currently know anyone of my patients that's on Belsomra right now. They just couldn't tolerate it. So interesting to see how that advances. Anybody have any other questions relating to the medications we talked about? All right, next slide. All right, so that was everything that we should see related to treatments and trials. Now, what do I actually see happen? Is not always, it's not always the case. It's not the end of the story, right? So possibly due to misdiagnosis or frustration with response to those treatment options. We also see a lot of patients as they're starting down this reduced cognition, end up with agitation and anxiety, which is totally understandable especially if you're aware of memory loss. It's super frustrating. So I typically see a lot of medications that I wish weren't prescribed. And these are some of the major classes of that. I see reached for antipsychotics a lot. Especially in my facilities, it's frustrating. I understand some people who are going through these cognitive declines really do get extremely agitated. We want to make sure they're not harming themselves or others, but we also want to make sure we're not taking away their rights. So I see a lot of antipsychotic use, and short term, if they're having an acute episode, may be appropriate if it's delirium, but it definitely has some side effects and some long-acting issues relating to dementia. So a lot of questions that I ask when I see antipsychotics used, and we'll get into a little bit more about each of those going forward. Another couple of medications I see a lot of trazodone used. And trazodone is an interesting medication, antidepressant class, can help with agitation on an immediate basis. It also can help with sleep. As well as treating underlying depression, but it has some issues itself we'll get into. And then benzodiazepines is our big class of hypnotics that are used in anti-anxiety also. So we'll get into all of these a little more as we go. All right, next slide. So the typical antipsychotics, these are our old medications. They have a lot to do with my job. So a lot of consultant pharmacists started going into facilities because we really were concerned with the amount of antipsychotics that are used on patients, possibly just to control them. So I still do see some of these used. Mostly now I'm seeing it in the hospice setting where we're not as concerned necessarily about the long-term effects, which is the biggest detriment of these. One of the biggest detriments of these antipsychotics is they can have long-term issues relating to tardive dyskinesia. These are the extrapyramidal symptoms that you see listed here. And they can be, if they're on these medications long-term, these can be non-reversible side effects. So I, again, go low, go slow, stay low. There are some instances where this may be appropriate, but dementia and cognition are rarely the choice, good choice for these. All right, next slide. After we saw these non-reversible side effects, they started coming out with some, we call them atypical antipsychotics. They have less of these extrapyramidal symptoms, but they have some problems of their own. And there are a lot in this class. So quetiapine is probably the #1 medication that I see prescribed. And a typical diagnosis is dementia-related behaviors. So, which again, it's not truly approved for that. And it's not really very efficacious for it. So it has, like I said, its own side effects. We see weight gain with this, increased cholesterol levels, lipid levels, increased blood sugars. So we do need some lab work done if we have someone on this. And we talked about it also affects the QT interval. So, and I also would want routine tests done looking for those extrapyramidal symptoms even on this. So within the first month, anytime there's a dose change within 30 days, and then every 6 months as it continues. But again, not a great choice for dementia. We also see, and we'll talk about what the black box warning is relating to this. All right, next slide. And that's this. The #1 reason we don't like using these is because in our elderly patients, we actually see an increased risk of death. And so there's been a number of studies. They just started seeing a lot of this. They were seeing an increase over 25% of patients that were using these versus the general population in nursing homes. And they're still not 100% sure. They know it has some of it has to do with cardiac issues. We talked about those QT intervals. They think that might be part of it. We also see an increased rate of infection in these patients, whether that's due to reduced physical ability with those dyskinesias it's causing, but they're not sure. We see an increased rate of pneumonia on patients on these. So, in some cases, we need to get through this period of agitation and anxiety related to dementia, but in the most cases, we'd like to reach for something else. Next slide. All right, so trazodone, like I said, that's an antidepressant. It works on serotonin. And it's multidimensional, so it definitely is working to reduce depression, but we see these low doses used a lot for agitation and sleep. And it can help with that sleep-wake cycle. We just want to make sure if we are what we're using it for. If we're using it for daytime agitation or anxiety, then a PRN is appropriate. But if we're using this at bedtime for sleep, then we want to make sure it's a scheduled dose. Because it affects that sleep-wake cycle. If we're using it for sleep, we want it every night. Otherwise, we can get what's called rebound insomnia with it. And as far as using it for cognition, there's just not a lot of data out there if it really does help with dementia or even a full-on delirium. Like I said, whether it's helping that agitation just due to sedation, it's still a question. I don't see a lot of its use, which is fine. All right, next slide. And then I do see a lot of benzodiazepines, both for anxiety and sleep. And we talked a little bit about some are better for certain indications versus others. Diazepam has a fast onset, but a long duration. So if it's something you would maybe use for an agitation or delirium episode or a high anxiety, someone with generalized anxiety disorder during the day. It's one I don't like to see used on a PRN basis because that long duration, or PRN would be as needed. So then move down the list, alprazolam, it has a more intermediate onset, as well as lorazepam, and they both have intermediate duration. So if we're going to use a benzodiazepine for some immediate anxiety issues, those would be a better choice than diazepam, and they won't have as much carryover. So those would be some of their choices for those. Again, that long acting, they may help someone get to sleep, but they're not going to prolong sleep. They also, if you have issues where you're getting up at night to use the restroom, if you have bladder issues, none of these are a great choice because of that effect on cognition and also increasing dizziness. They do lead to an increase in falls. So always kind of playing, what's working best, what's our best option. These also are a Schedule 4 medication, which we know can lead to some dependence with people. It is hard to get people back off benzodiazepines. They do start to become reliant on them. But some people with true generalized anxiety, we can't get away from using them. But again, we're going to watch for side effects and make a better choice based on, how fast the onset is and how long the duration is. Next slide. Popped in the Beers criteria on the bottom. So back to like diphenhydramine, benzodiazepines. Beers criteria is a whole list of medications that was developed by Dr. Beers that he looked at what medications are having the most detriment and most side effects in our elderly population. And this is one of those medications. Right. Again, excuse me. Again, none of these medications are FDA approved for dementia, but they are often used. And we always want to keep balancing. Is it helpful? Is it harmful? Who is it benefiting? And this who is it benefiting question is a good question because we know when we start to see memory decline, it's not just the patient who we're dealing with. We're often dealing with family members also. So sometimes we need to look at, is this medication a best choice for the patient and their situation? Are we possibly appeasing family members? But is it the best choice for the patient? And just make sure we're not further harming them or causing more issues for them. Like we've talked about, so many of the things affect sleep, and we know poor sleep is a contributor to poor cognition. but are we making poor sleep worse, for example? All right, next slide. Okay, other treatment options. So we talked about all the questions we get related to supplements, right? And supplements we can get access to. So a couple of the big supplements we get asked about, vitamin E, and they're as an antioxidant. Has been around a while and it's been touted. Mostly we're seeing vitamin E related to heart health. And I haven't seen any really good studies that show great benefit relating to cognition. There's a couple out there that show it may delay cognitive decline, but when they came down to testing scores for that, they couldn't prove out anything. But we still continue to see it for heart health. The one caveat I would always talk about people with using vitamin E is make sure to monitor if you're on something for blood clotting, is it can interfere with clotting mechanisms and increase your bleeding risk. So be careful, especially about high dose vitamin E. And then vitamin B, there's a more recent study that we listed here that talks about vitamin D usage, or B usage, and there's a whole lot of B complex out there with varying amounts of B1, B2, B6, B12 in them. We do know that especially vitamin B12 plays a role in depression. And we know that depression can mask or can exhibit itself as memory loss. So some of the B vitamin usage may be relating to supplementing B12 and improving depression scores. So bear that in mind. But this study did show that it may be able to delay some memory loss and maintain current status. So B vitamins are innocuous, pretty much. They're water soluble, so it's hard to get a lot of extra. You know, talk to your prescriber about whether you should be on a B supplement. There are some medications used to treat diabetes, like metformin, that it can actually has been shown to cause some B vitamin deficiencies. So especially B12. So definitely if you're on metformin, it might be something to think about talking to your prescriber or your pharmacist about. All right, next slide. All right, some other treatment options besides prescribed medications, diet and exercise can definitely play a huge role, and minimal economic impact, right? There are a lot of different diets out there. Examples: Mediterranean, the DASH, and the MIND. The MIND is kind of an interesting one. It's a combination of the Mediterranean and the DASH. And we started looking at these because we saw people that are in the Mediterranean seem to have lower or better brain health and better overall health, cardiac related. So how is their diet different than ours? We see a lot of whole grains, vegetables, fruits, nuts, and olive oil added. So there's a lot of talk out there about olive oils and those omega oils, fish, dairy, and poultry also in their diets. The DASH is a slightly different one. It also focuses on fat-free dairy, poultry, some different beans, and it's a very low fat, low sodium, whereas the Mediterranean didn't really look into the fats and sodium as much. And then the MIND is kind of a combination of those two, the best of both worlds kind of issue. But overall, low fat, low sodium, and incorporating increased grains. We know that whole grains help pull lipids. All these vegetables, nuts. They have a number of vitamins related to them, and that can be beneficial. So, and oils, good fats, right? When we say low fat, we don't mean all fats. So definitely diet plays a huge role, and exercise can play a huge role. We know that exercise stimulates serotonin release. So it's recommended 30 minutes, 5 days a week. I can't say I always get there, but definitely even just going for a walk, being up and about. I think our current pandemic has led us to some sedentary lifestyle. So get up and get moving definitely plays a big role. Next slide. All right. So these are some other things people often ask questions about. There are no proven benefits to any of the following that I've seen good articles about. We can discuss any of these you want to. And they all have different relations. So we talked about fish oils a little bit in the last one, statins. The person had a question about ketotofen. That's that anti-inflammatory. More than willing to discuss any of these. I will go back. I know there was a question here. Let's see. Go back up here. If I can get to it.
There's a couple questions. I can get them for you if you'd like.
Okay, I think I found it. That the
you got 'em?
SSRIs and their impact on cognition. So SSRIs are the serotonin reuptake inhibitors. Those are antidepressants like citalopram, fluoxetine, and they can have some effect on cognition. We know that just depression in general, we know in fact affects memory. So we definitely want to recognize the difference between memory loss and depression and treat that underlying cause if it exists. The SSRIs as a class can have some side effects. They can have some anticholinergic type side effects. So dry mouth, constipation, and then some issues with bladder, and also some slowed cognition. So we do see that. They also can, because of that effect on your serotonin, can affect sleep in some people. They can also contribute to, if you're late on taking a dose or you miss a dose, they can cause headaches, which can affect cognition. So that would be how I would see them impact cognition. Overall, I don't see like a generalized improvement or decline in overall cognition being on them from my clinical background. I also antidepressants. So unless I'm seeing sedation from them or things like that, I know they can also have some heart health benefits to people who are depressed. So it's something to discuss with your physician. They all have some slight differences in side effects. So if you're seeing some change in your cognition on one, we might be able to find a different one that works better for you. So it's definitely not none above asking your prescriber about. All right, and then looks like a question about supplements advertised on TV. Prevagen is just the greatest thing. So they say, is this just snake oil? Prevagen, it comes from a protein from jellyfish. I'm not sure how we decided that it would help with memory. I'm not sure. The size of that protein is pretty huge. So taking it orally, I'm not sure you're even absorbing any of that protein. And there have been some studies that show Prevagen can actually worsen cognition. So it's not something I would recommend. It's pretty expensive. Again, all of these, I'm not going to tell you don't take any of them. Most of them are not harmful. So if you if you want to spend your money on it, you want to try it, you know, talk with your prescriber, talk with your pharmacist, make sure they're not interacting with something you're already on. Like anti-inflammatories, non-steroidal anti-inflammatories can cause some increased bleeding risk. So I'd want to make sure you're not on something that would impact. Ginkgo also can do that. Vitamin D, again, the amounts of vitamin D are important. It is a fat soluble vitamin, so you can get too much vitamin D, but there are some disease states that cause vitamin D deficiency too. So in some of those, it might be appropriate to have, but overall, on this list, I find Prevagen to me the most frustrating. It's super advertised right now. And like I said, I don't even know if you're absorbing any of it. If you're not having decreased memory issues when you take it, is it harmful to you? I don't know. I don't think so. But it's not something I recommend. All right, what else? All right. Let me know if I miss any of these. Curcumin is another anti-inflammatory. What about curcumin? If I cannot take NSAIDs due to other prescribed meds, curcumin has the same interaction as some other NSAIDs do. So again, I would discuss it with your physician, but I know that it can also increase bleeding risk. So some people, they don't, it's not as impactful on that bleeding risk as other people, but it's definitely something to keep in mind. And I would talk to your pharmacist or prescriber to see what's your reasoning for not taking NSAIDs and if it's related to bleeding risk. How and why is dairy limitation recommended? That's a good question. I know that lactose can have an impact for some people, and I'm not sure if that is why or not. I don't know, maybe Dr. Chin has a take on that. I am not sure how the dairy limitation comes into this. And did I miss anything else?
Dr. Chin, do you have any input on why dairy is recommended to be limited from the MIND diet and the other diets that also ask for that to be eaten in small doses from us Wisconsinites?
You know, a lot of times people will talk about dairy in the context of saturated fat and how that can be, you know, how that could potentially be a cardiovascular risk factor. Other people are interested in the whey protein and the type of protein in dairy that can be upsetting to a person's stomach and actually cause inflammation. That's more still being investigated than it is something that is just generally recommended, but oftentimes it ends up coming to cholesterol and fat. And I will say it's much more complicated than just using those two words of cholesterol and fat. And so there's different types of fat there, and there's different types of milk products and dairy products. So it gets it's difficult for one general recommendation to apply to everyone, which is, you know, difficult for the government agencies and public health. But that in general is my understanding of why most of these studies are trying to limit dairy. As someone who still believes in the MIND diet, I don't myself limit how much cheese that I eat. So,
Spoken like a true Wisconsinite, Dr. Chin. And then Dr. Chin, one of the questions Anne was giving before was talking about Prevagen, and I know her take is similar to our take from the Alzheimer's Disease Research Center, but would you mind giving a little input on what you would prefer people spend money on potentially rather than spending it on Prevagen if they really want to try to make a difference?
Yeah, I will say that Prevagen has done a wonderful job with their marketing. I think they have lots of advertisements. It's all very catchy. You wish you could support local because it is a Madison-based company. However, They did 2 studies internally that showed potential promise, but then there were 3 or 4 studies, small studies outside of the company that didn't show any benefit. And when I've looked at those particular studies and the comments on those, there really was this idea that the compound itself, this aqua or apoquarin, that's nicely written on the screen, that's actually broken down in the stomach and it's not reaching the brain, and that would be a reason why it's ineffective. I also just think in the studies, the outside ones, they just didn't show benefit. And so unfortunately, the evidence just doesn't support it, but it's also $80 a bottle for a full month's worth. And that's a lot of money. And so for something that hasn't been proven, or really that doesn't even have a biological plausibility to it. And I say that because if a person is deficient in a B vitamin or vitamin D, there is a biological reason why replacing that can be helpful to a person's cognition and health, but not with Prevagen. And so instead of spending $80 on a supplement, I've encouraged my patients instead, this is pre-pandemic, to join a gym and go to a gym to exercise, since there's more evidence for exercise. Post-pandemic, in the midst of the pandemic, I've encouraged people to consider home equipment or to have a Mediterranean meal. So you could spend that money on some salmon and mixed nuts and salad, which would actually provide more benefit to you. So there's other ways that we can spend $80 other than, unfortunately, a supplement that just isn't being shown to work.
Thanks, Dr. Chin. And then I want to make sure we answered this question we may have. Is there a connection between fish oil and heart disease?
So this has been so actively researched, and it goes back and forth. And to my knowledge, the most recent studies were not showing a positive, they do not show a negative relationship, but they have not shown yet a conclusive positive relationship between taking fish oil and reducing primary cardiovascular disease. But there are studies prior to that and in smaller subgroups that have shown potential benefit. And so it's really difficult to know when and none of these really are what we call randomized controlled trials, where a person is, you don't know what you're receiving and it's the one variable that you're not controlling for. Those are our gold standards, but they're very hard to do and very expensive to do. One of our colleagues, Dr. Cindy Carlson at the VA, is doing something with fish oil, therapeutic prescription dose fish oil, and looking to see if it's beneficial. But as of now, it's more of, sadly, it's just mixed. We don't know, and it's not being used as a therapeutic standard of care in patients. That being said, many people in the community take it. I put in the earlier comments that I thought that would be the most popular one prescribed, because I see lots of people taking it. I don't personally have a problem with it. There are very few, if any, side effects from it. And I think there's all rationale so why it could be helpful, but I just want people to know the evidence isn't there right now to support that.
Thanks, Dr. Chen. And then we have another question, is ibuprofen and NSAID?
Yes, it is. Yes, it's probably the most common used non-steroidal anti-inflammatory.
And we have another question on the Bresden Dietary and Supplement Protocol. Please comment on what that is and what we know about it.
I'm going to defer to Dr. Chen. I'm not aware of that one.
Yeah, so Dr. Bredesen is a researcher and scientist from the Buck Institute. I believe that's out in California, or he was a part of that group. And he came out with a book called The End of Alzheimer's Disease. It's a very popular book. I've both read it and met Dr. Bredesen to follow up on some of these things. Many of the things Dr. Bredesen mentions in his book are supported by what we do at the Alzheimer's Disease Research Center in the WRAP study. These are those lifestyle interventions, the sleep the diet, the exercise. He goes further to talk about supplements and certain blood tests that one should get. And that's where we start to separate. And not that I think there isn't plausibility to some of the things that he's talking about, but there isn't the evidence to support what all the tests that he wants to get and all of the supplements that he's recommending. So to answer the question about, so the supplement protocol, I do think is extensive and also expensive. Someone has looked at it and said that would cost hundreds to thousands of dollars on a, I think, quarterly or biannual basis. So it's not a cheap thing to do without having a lot of evidence. But then as far as the dietary approach, he very much subscribes to the Mediterranean type of diet. One of the things that he recommends is this idea of what's called a 12-3 fasting, where you are fasting for 12 hours and you are not eating 3 hours before bedtime. And we've had this kind of discussion for those who have been in our course before. We've talked about fasting in the past. I myself am an intermittent faster, so I fast for over 12 hours and I feel better with that. But that isn't something that I recommend to patients simply because it doesn't have the evidence right now to support it. And certainly you should talk to your primary care doctor or provider to get a sense of if that's something that would be safe for you. Certainly there are adjustments that are made as you were going through that process, but the rationale was discussed in one of my podcasts, and Dementia Matters. It was a very popular podcast. I would encourage you to go to that and look at it. That was one of the original researchers who was looking at fasting. And there's some evidence now, particularly in animals though, to suggest that fasting could be helpful. I don't think 12 hours is a lot. I know it sounds like a lot, but the idea that we shouldn't be eating right up to the point that we go to bed, I think is valid. 3 hours is a lot. I've tried it. I've not succeeded yet. I still believe that it's a good thing, but I myself will snack up until about an hour, if I'm lucky, 2 hours before bed. But if you were to stop eating, for instance, at 8 p.m. and you didn't have your breakfast until 8 a.m., that would be a part of what Dr. Bredesen has recommended. I don't think that's an outrageous thing to do. I just think we have to be careful. But that too itself, this idea of fasting is exciting, but it's still being investigated before it reaches something like a public health announcement. We're just not there yet.
Thanks, Dr. Chin. So I know, Anne, you wanted to talk a little bit more about pharmacy tools and things that can help remind you to take your medication and taking your medication when you're supposed to be.
Yeah. This is a big program that we have at O'Connell's, and we have done some analytics on it and have found we early on, we stopped doing them, but we had early on done analytics. We have over 100 people on medication boxes that we fill every week at O'Connell's. And those are little MedMinder things. Some people get plastic boxes, some people get paper disposable ones. We go out every week and deliver them to their homes. We don't charge anything for them other than filling the prescriptions. But early on, we did some analytics, and we did initial patients and how often they went to their primary care or they went to an urgent care or were actually admitted to a hospital. And we saw a reduction in urgent care, emergency room, and hospital admissions on our patients, which we started on our MedMinder systems. So that was all as far as we took it. We didn't go farther with that. But we did see that a number of reasons we think why missing medications played a role. We also would see people that not just the immediate impact of missing a medication, but because they weren't refilling things like they should have, we think that when they got in a situation, we started on a med box, we actually had doctors reducing doses because they were actually now taking their blood pressure med every day and found that they didn't need as much because they weren't missing it every other day. So we're seeing that kind of an impact. We also, with our use of pain medications, it better helps us manage how often someone is taking a medication throughout the day. If they only have what's in their med box, they can't overtake their medications. And we do see some people with cognition issues where they can't get 4 weeks of medications at a time. They're only able to handle week's medications at a time. And we are managing that for them. So it takes a little stress off of them, sometimes helps them reduce anxiety. We do see a lot of phone calls with these patients and their family members. Sometimes it's a family member initiating it. Sometimes we have prescribers calling us saying, can you call this patient and encourage them to use your system? We are getting a lot of referrals through this. But it lends itself to sitting down with the patient and their family and looking at all the medications they're on. As Dr. Chin did hit on, we do see a fair amount of supplement use and just prescribed medications. When we talked about our average patient being on 13 meds, we definitely take a hard look at what do they really need to be on, what could be interacting, what's the best time of day to be taking these, are there things we can eliminate, are there things we could consolidate, are there better medication choices? Even if you don't need a MedMinder system, I do recommend that you try to sit down either with your prescriber or a pharmacist and discuss all the medications, including over the counters that you maybe don't purchase at your pharmacy, that specific pharmacy, and talk about, what can we reduce this down to reduce this pill burden. Definitely polypharmacy and pill burden are a huge issue going on right now. Anybody have questions relating to that?
There's not a question related to that, but we do have a new question about is Tylenol a problem medication?
All right. I'm not sure referring to a problem medication in relation to memory or just in general. Tylenol or acetaminophen is probably also a #1 pain medication that's used, also a fever reducer. Doses can get to be excessive, and some people are using it for pain medication. So we do try to limit the amount someone gets prescribed or takes. And that has to do with long-term effects on the liver. There are a lot of pain medications that include Tylenol as a part of them. So we do look at overall accumulation of how much acetaminophen or Tylenol is being used in a day. And then any pain medication obviously can affect cognition somewhat, so could affect memory that way. In most cases, it's a better choice than non-steroidal anti-inflammatory, because the non-steroidals have an increased bleeding risk, but not always. It's not always the best and the best choice. So it depends on your situation.
We've got another question.
Yeah.
I'm not sure how long-acting injectables work for antipsychotics, but is there a future in long-acting injectable medications for memory-related meds as opposed to daily oral medication?
Yeah, I don't know of any long acting memory meds out yet. Like we know that that new antibody, anticlonal antibody that is out for as an infusion that's given once every 4 weeks. It's not long acting. I think it's given that frequency based on how it works, but not that it's a long acting medication. The long acting injectables, they work in a long acting fashion due to the way the absorption happens. They're in an oil base and they have a slow absorption rate. So they're given mostly in the gluteal muscle, which is a pretty large muscle. And that's how those work. It would be an interesting thing to study. Maybe we'll see something coming out where someone studies some of these memory enhancing anticholinesterase inhibitors. The chemistry behind it, I'm not sure that it would be viable as a long acting injection. That would be my take on it.
She just further comments on this question. I only ask because it seems remembering to take the meds daily is often an issue.
Yes. Yeah, it's definitely, I understand. Yeah, when we talked about some of those medications, there is the Exelon generic patch that is available. So that is one way of taking a memory enhancing medication that you don't have to remember as often. It's a 7-day, if I remember right. It's been a little while since I've dispensed one, but it is a longer acting patch that you don't have to remember to use on a daily basis. But yeah, you're right. These medications we're using to enhance memory rely on us to remember to take them. So definitely an issue related to it.
And Dr. Chin and Anne, do you guys have any thoughts on the medication boxes that might be locked and have the reminder and then open up the medication the person is supposed to take for that time? Or those that just have the clock on it, right? That rings every so often when you're supposed to take the medication. Have you seen success with those or?
Yeah, so O'Connell's has used them in the past. We don't currently have anyone. And when I worked at Oakwood, we also had a number of patients use them. Some limitations with them are they do often need to be, they often are limited to 21 slots at most. So that would give you a week's worth of 3 times a day dosing. You still need someone that's locking and unlocking, filling, and setting those up. A lot of them do have battery backup, so outage of power is helpful. And so I see our decline in use, I think, was based on some of these patients are still living by themselves. Whether we want to put on our delivery person the liability of switching out those trays with something. Another issue we saw is the memory declining so much that they're not even recognizing when it beeps that indicates taking medication. So in some instances it's great, in others it just doesn't work. But can you still remember what the alarm is for, and are you able to switch out trays within it? So it is dependent on the level of decline in cognition.
Yeah, and I don't have any particular experience in using the automated ones that Anne's referring to. And I think, Anne, you've done a nice job really summarizing the potential benefit. I see a lot of potential downside or at least complications to it. I'm a huge fan of the pre-made med boxes, and I recommend to many of my patients simply to reduce the burden as well as the concern of accurate organization and it allows for family members who may not be living with a person to check in and see about adherence or any sort of issues that might be coming up with taking medications. Oftentimes that's when you can see a med box allows you to see that you might be missing certain medications. So I find that to be very helpful, and one of the most popular things once people are willing to try it. There's a lot of initial concern in the beginning, but once that happens, people really do seem to like it. But I also think a lot of the med box and this idea of the automated system, it does come back to medication reconciliation, knowing exactly what you're taking and why you're taking it, because then at some point some of these medications aren't needed anymore, or adjustments are needed, but ideally not needed. And so trying to get to the lowest number of medications is a worthwhile thing to continuously be addressing. And that can be done with a pharmacist as well as with primary care doctors and specialty care doctors. But I do think it comes back to, we don't want to be on 30 medications and supplements. The lowest number we can be on is the best. And still having a good healthy diet and still having those lifestyle things really to truly supplement what is absolutely required.
Yeah, Dr. Chin hit on quite a few things there. So we have a number of adaptive systems. So like I said, we aren't using the automated systems on anyone right now, but we do have we run into resistance with patients. So we'll often start with a 4x7 box that each door can be opened. So they still have some control over their medications. They haven't lost complete control. But like I said, sometimes we are reduced down to a disposable box. We know exactly what day they've punched out, because we will see in those open doors, sometimes they miss their meds. They just dump them to hide it. So it can be an issue. But we also need to work with them and what their goals are and what they're capable of. So we do try to work those issues out, and we will track if they want us to track, how much they're missing and report back. We can do that either with a family member or with a prescriber, whatever we work out at the beginning, and we're adaptable. If people are finding something's not working, we try a different system. We do have also our capability. We can make strip packs. So we can do a strip of medications where it's just one after the other, and we can set that up. We can set it up. It's a whole week's worth, and it's one after the other, or we can do just a day's worth at a time. But we keep looking at different systems and what works for patients, because we know we're not all the same.
I've just had a few comments in here just to kind of add to the discussion that we've been having so far. Cassandra says, what about patients that forget they took their medications and continue to take them to the point of toxicity or ER visits? And then Marilyn shares that pre-made med boxes with the use of Alexa type voice reminders are helpful, but the voice reminders may also be ignored over time. So I don't know if Anne or Dr. Chin, if you guys have any additional comments related to those two comments that were shared.
Yeah, we have experienced issues with toxicity. Sometimes we'll have a basic med box, and then if there's medications they're concerned about overuse, those might be in a separate box or a separate card. They may have a caregiver that comes in, and those are separated out of the box, and only the caregiver has access and gives those at the time that they're on site. So that's one way we can deal with those overusage issues, and maybe their whole box is set up that way. It's, we try and reduce the number of administrations throughout the day to the minimal number, and then that's when a caregiver is present for that person, is one way of handling that.
I think both questions speak to the reality that we have. I mean, working with pharmacy, I think, is a great piece of information that I hope everyone takes away from this, that they don't dispense medications, that we can work with them on different creative strategies on how to organize and take medications. Same thing with Alexa and technology. But at some point, if your condition changes and therefore you're having more symptoms or having difficulties with taking medications or overtaking medications, that does usually tell us that these compensatory strategies that we're talking about aren't going to work anymore. And at that point, you would need more support, more care. And what that looks like then is going to be potentially different for the individual, but that usually means having someone present to organize those medications and administer those medications, whether it's at home or in a care facility. But I don't think there is a solution that a person on their own will be able to have full control and independence in taking medications in a condition like cognitive impairment. So it's sort of like, it's again, advanced care planning. You know, a person, we want people to be as independent as possible, but then knowing what the future could be and would likely be as far as some of those changes, preparing for what that would look like and having people in place or knowing who to go to so that those things can be taken care of.
Yeah, I think those are great comments. I was also going to, just add to that discussion that, this really is all about a personalized approach to your medication management. Not every way that we have available will work for everybody. And so really having those conversations with your provider, with your pharmacist, with whoever you decide you want as part of your team, your care team, all of those discussions are really optimal when they're had early. So I think those are great comments to think about, knowing that this is a diagnosis that affects our memory and our day-to-day functioning. So yeah. People are more than welcome to continue to put some questions in the chat. Or I think the meat and potatoes of our education program are completed now, right, Anne? You've gone through some really wonderful information and taken a deep dive into the medications that are typically prescribed and how they, what are some of the effects that happen after they're taken, and some great strategies to deal with medication management. And I really want to thank you for your time and your pinch hitting today.
Yeah, thank you. I hope I didn't bore anyone. So I'm like, I find it interesting, but not everyone does. Yeah, and you can, if people have more questions, feel free to email me. I think my email was on an earlier slide, or call O'Connell's and ask for myself or Holly. We're O'Connell Pharmacy is still a family-owned business. We're more than happy to do those extra steps. I mean, we call it health care for a reason. Is kind of our motto. So I mean, this is just one condition that we know needs a little extra touch. Like you said, it's continually evolving for a person and their family and caregivers. So we're willing to continue to evolve our system to adapt as much as we can. We even have people that move into an assisted living and continue to use their med boxes for administration, just because it's what they're comfortable with until they reach a point that that's not working. So, we work with them all the way through it. So
wonderful. We're glad that we have pharmacies out there that do this kind of more intensive and personalized work with all of us. It's, I think, an underutilized resource our pharmacists are to help us navigate some of the medications that we're taking and why we're taking them, and even how to facilitate conversations with our providers about why we're taking those meds. So
yeah, definitely a part of the team and a team effort.
Mm-hmm. So we have our upcoming events. So we're closing out our 2021 speaker series for Healthy Living with MCI, but we will be back in 2022, and we will actually be back with a few more presentations. We're going to be lining up 6 presentations in 2022 as opposed to 4, and our first presentation will be on January 14th, and the topic will be clearing the air about cigarettes and the aging brain. So we would welcome everybody to come back and learn about that particular topic. And then also Living Well with Chronic Conditions is a 7-week workshop. It's an evidence-based workshop that is facilitated through the Alzheimer's Association specific. This is a program that's run all over the United States and in other countries as well. But we take a specific focus on mild cognitive impairment and early stage Alzheimer's disease and other dementias. And what I would say about this workshop's connection to the topics that we talk about in this particular speaker series is that we take deeper dives into these topics. So earlier this year, we talked about sleep hygiene. We have a whole component of living well with chronic conditions that focuses on sleep hygiene and how you might be able to build action plans to help improve sleep. We have a whole section dedicated to medication management and how to have conversations with your healthcare provider. So for more, some of that, like we talked about, those individualized or personalized approaches to how you manage this from a chronic disease standpoint, this class could be really helpful for that. We take really big dives into nutrition and exercise, making difficult decisions. There's just a number of topics that we talk about over the course of 7 weeks. And so if you're looking for more help on some of these topics that we talk about, connecting to us and signing up for those Living Well with Chronic Conditions classes could be really beneficial to helping you succeed in managing this from a chronic disease standpoint.
And after today's program is finished, I will be sending out an email to everyone that will have the slides, and it will have information about these upcoming classes and how to register. And it will have Ann and Holly's contact info. So you'll know how to get in contact and get answers to the things we've talked about. And then we just have a couple more ways of how you can stay connected to the Alzheimer's Disease Research Center and the Alzheimer's Association. Dr. Chin, would you like to talk about your podcast?
Well, for those that haven't attended before, we have the ADRC and the Alzheimer's program at UW has a podcast called Dementia Matters, where I interview researchers, community members, clinicians on Alzheimer's disease caregiving and any issues related to cognition or how the brain is functioning. And the point being really trying to translate what is happening in the scientific and clinical world to the community so that we can take the key points of all of this work and effort. Each episode is 15 to 25 minutes long and hopefully is entertaining. And we do have new episodes about twice a month. I think we're going to take a brief break over the holiday and we'll be back in January. But if anyone does listen, they have topic ideas, please also go to the website at the ADRC and submit those, because we do appreciate that. And we're trying to always expand to make sure that we're addressing as many issues as we can. You can listen to it on the website, but also on any sort of podcasting app on a computer or smartphone.
Thanks, Dr. Chin. And then the Alzheimer's Disease Research Center and the Alzheimer's Association both have e-newsletters. Our e-newsletter goes out once a month, and we feature the podcasts in there and other upcoming events and updates and news from the Alzheimer's disease programs at the UW. And then the Alzheimer's Association e-newsletter comes out once a week with updates on programs and things happening within the association that people would like to know about. And I'll also include this information in that email so you can sign up. And then please feel free to connect to us on social media. You can find us on Facebook, Twitter, and YouTube. So please go ahead and reach out and stay connected if you'd like. We're always sharing useful, helpful brain tips, especially on Wednesday, Wellness Wednesdays, just to make sure that you're getting some good brain health information on a regular basis. And if anyone from the program today is interested in learning more about being a research participant You can fill out a form online, and myself or my colleague Kelsey will contact you and tell you more about research opportunities. So thank you so much for everyone who has attended today and spent this time with us. We really appreciate it.